Biliary disease refers to diseases affecting the gallbladder, bile ducts, and other structures involved in the production and transportation of bile. First, let's revise the anatomy of our biliary tree. It's worthwhile familiarising yourself with this to help with your understanding of biliary pathology. The left and right hepatic duct can join to become the common hepatic duct. The cystic duct joins the common hepatic duct to form the common bile duct. The common bile duct splits into the pancreatic duct and the ampulla of Vater, which is the connection between the biliary system and the duodenum. The gallbladder is split into three anatomical regions: the fundus, the body, and the neck. The presentation for biliary disease can differ slightly depending on the exact pathology. However, common presentations include sudden intense pain in the right upper quadrant, usually worsened by eating, pain which radiates to the right shoulder blade due to vagus nerve irritation, nausea, vomiting, pyrexia, jaundice, light-coloured feces or dark-coloured urine, bloating, and pruritus, which is an itching of the skin due to a bilirubin buildup. It can be difficult to distinguish between the names of biliary disease pathologies. Let's look at what breaking down the word can tell us. Cholecystitis is an inflammation of the gallbladder due to bile being trapped by a gallstone. Cholecyst is derived from the Greek meaning gallbladder, and itis is a suffix for inflammation. Choledocholithiasis. Let's break this word down again. Choledochol means common bile duct. Lith means a stone. From this, we can assume that there is a stone in the common bile duct, which is correct. Choledocholithiasis is an obstruction of the CBD. Other biliary pathologies we will talk about in this video are gallstone pancreatitis, ascending cholangitis, and biliary colic. So what's the difference? Gallstone pancreatitis is caused when there is a gallstone blocking the pancreatic duct. Ascending cholangitis, also known as acute cholangitis, is an infection of the biliary tree and is usually accompanied by obstruction. When bile sits for too long, it can begin to thicken. This is known as biliary sludge and is an ideal growth medium for bacteria. Finally, biliary colic, also known as a gallbladder attack, usually occurs after eating, when the gallbladder contracts and causes a gallstone to temporarily block the neck of the gallbladder or the cystic bile duct. This is temporary but can eventually progress to cholecystitis. Let's try to differentiate between these different pathologies using their presentations. Most biliary pathologies result in pain in which area of the abdomen? The right upper quadrant. And we would expect a patient to be pyrexic when there is inflammation and infection present. Is there inflammation present in cholecystitis? Remember, cholecystitis means gallbladder inflammation. So yes, we would expect a patient with cholecystitis to be pyrexic. We would expect a patient to be jaundiced if there was an obstruction in their common bile duct causing a build-up of bilirubin, so we wouldn't expect to see either of these things in cholecystitis. Amylase is a marker of pancreatitis, so we wouldn't expect to see that raised. However, our inflammatory markers CRP and our white cell count would both be raised again due to the inflammation. In common bile duct obstruction, we can expect to see raised bilirubin in the LFTs, potentially leading to jaundice. If there is no inflammation or infection, our inflammatory markers should not be raised, and the patient would not be pyrexic. We would not expect to see raised amylase. In gallstone pancreatitis, the pain may radiate more from the epigastric region. We would expect the patient to be pyrexic and have raised inflammatory markers due to inflammation. However, there is no common bile duct blockage, therefore no raised bilirubin or jaundice. Remember, ascending cholangitis is infection and obstruction of the bile duct. Therefore, we can expect the patient to be pyrexic, potentially jaundiced, have raised bilirubin and inflammatory markers. With biliary colic, we expect to see pain, but no other signs of blockage, inflammation, or infection. Let's start our examination with an end-of-bed observation. Patients who are in pain can be tachycardic, hypertensive, or tachypneic. A patient who is pyrexic indicates the presence of infection and inflammation. As well as looking to see if a patient is jaundiced or vomiting, we should also ask this when taking a history to see if they have experienced any recent vomiting or yellowing of the skin and eyes. When performing an abdominal examination, we want to look if the pain is epigastric or coming from the right upper quadrant. Epigastric pain may indicate more pancreatitis. However, this isn't a strict diagnostic rule and further testing is always required. When taking a pain history, we want to use the Socrates method. We also want to test for Murphy's sign. A positive Murphy's sign is elicited in patients with acute cholecystitis by asking the patient to take a deep breath and hold it while deeply palpating the right subcostal area. If pain occurs on inspiration when the gallbladder comes into contact with your hand, this is Murphy's sign positive. We also want to remember to look for our red flag signs. Rebound tenderness, also known as Blunberg's sign, is a clinical sign in which there is pain upon the removal of pressure. This could be a red flag sign for peritonitis. Always be sure to rule this out. In our blood test, we should ask for a full blood count to determine if the white cell count, a marker of infection, is raised. Our LFTs, high ALP and bilirubin, can indicate a blockage. CRP, our marker of inflammation, and amylase, a marker of pancreatitis. We should also remember to get U's to check if anything is wrong with the kidneys. As often, right upper quadrant pain can be confused with right flank pain. Remember, if you're prescribing morphine for a patient in pain, you may also need to prescribe an antiemetic, as morphine comes with the side effects of nausea and vomiting. Remember to investigate your red flags. All patients should receive an erect chest x-ray. This shows us if there is any free air beneath the diaphragm to rule out bowel perforation. Ultrasound and CT are also first-line imaging tests for gallstones. You can see a large gallstone in the gallbladder in this ultrasound, and multiple stones in the gallbladder in this CT. A more specialised diagnostic imaging test is MRCP, which stands for magnetic cholangiopancreatography, a special type of MRI scan which creates a clear picture of the biliary tree. Symptomatic gallstones can be treated using ERCP or surgery. ERCP stands for endoscopic retrograde cholangiopancreatography. It combines X-ray and the use of an endoscope to remove gallstones. A cholecystectomy for recurrent gallstones is the surgical removal of the gallbladder.